What do you say, Megan? Shall we make a start?
Yeah, okay. Let's get this show on the road.
Okay.
Dun 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 dun.
So, hello everyone, and thank you for joining us. Welcome to today's online pod, Pain Management Awareness for Meditation Teachers. I'm Lisa Ford, Treasurer of Meditation Australia, meditation teacher and teacher trainer, and I'm co-hosting this event today with the wonderful Megan Spencer, a mindfulness meditation teacher, also from the Board of Meditation Australia, who has organised this event today and brought this wonderful panel of experts into this meeting. So thanks, Megan.
Thanks, Lisa.
So to begin, we acknowledge the original people of the land upon which we now sit, the Boon, Wurrung and Wurundjeri people of the Kulin Nation. We recognise their everlasting connection to land, waters and culture. We pay respects to our elders past, present and emerging. Let's take a few moments in silent meditation to ground ourselves and to honour this connection. Thank you very much. That was a beautiful way to start today. So today's topic is of great value. In 2018, the ABS reported 3.24 million people suffering from chronic pain, and 68% of these were of working age. This is set to rise to 5.23 million by 2050. These are staggering figures. So as a meditation teacher, chances are you will come across students suffering from some sort of pain in your groups. And maybe you already have, that's what's brought you here. So a brief rundown of how this afternoon will work. Megan's going to begin by telling us a bit more about how this pod came about, and she's going to introduce us to the experts on the panel who have so kindly offered their time today. Then Megan and I will be asking some questions of the panellists. We'll then be breaking up into groups for some peer discussion, and we'll then invite some questions from you, the attendees, to the panel. All the attendees are currently muted, and can I ask you to remain so so that everything's clear and audible, and also thank you very much to everyone for turning off your video so that we can ensure the event runs really smoothly. The event will be recorded and the recording will be made available to those who've registered for this event. So regarding your screen view, some of you may find it easier and more comfortable to watch this online event in speaker view rather than gallery view. So gallery view has everyone visible on the screen. At the top right of your screen, if you wave your mouse around, you should see an option to change to speaker view. Now, speaker view then allows you to see the person speaking rather than the whole group of people that are present. It's completely up to you, whatever feels more comfortable. So for now, I'm going to hand over to Megan to introduce the topic and the panel. Thank you so much, Megan, for organising this event.
Oh, thank you, Lisa. Thank you for a beautiful introduction. Thank you for the little sit we did and the acknowledgement of the lands that we're on. I'd also like to pay my respects to any First Nations people who may be present today or their representatives, and acknowledge the traditional owners of the land that I'm talking to you from, which is the Gunner people of this Adelaide Plains in South Australia. I'd also really like to say that it is a group effort, this panel today. I'm very grateful to Lisa for coming on board and being so incredibly supportive. I'm so grateful to the speakers as well, who you'll meet in just a moment. And I'd also like to send out a big thank you to Karen Stone and Paul Majewski from Meditation Australia as well, who have also been part of making this event happen today. Pain management awareness for meditation teachers. And just to give you a little bit of a background on how this came about, there was here I go, hang on, how far do I rewind? You might have heard about this little thing called COVID-19 pandemic that we're in. And not trying to say that it's been an easy time for anybody, and it's been much harder for us, comparatively, some rather than others. But around this time, in July actually, there was meant to be the second Australian Meditation Conference presented by Meditation Australia. So it was meant to be in July, and then the pandemic came along and it's been postponed until next year. So as part of the conference, I suggested perhaps we might like to do this particular topic, pain in the body, or pain, as we're calling it today, pain management awareness for meditation teachers, with a chat with an internationally renowned mindfulness-based pain management expert, Vijamala Birch from Breathworks in the UK. Vijamala was coming out in February to teach a retreat which I was attending. I've done some introductory Breathworks teacher training before with her, and she was coming out to Victoria, to Australia, to do an immersive retreat. So I suggested while she was here perhaps we could involve her. She wasn't able to come over in July. So the suggestion was that we film an interview with her. I interview her at the retreat, we bring it into the conference, and then do a live, in IRL, in real life, face-to-face panel discussion around the themes that come up from that particular interview at the conference. So I guess you could say this is the online version of that. We absolutely wanted to provide this video as a resource for you. And this discussion as well, and it's a way for us to stay in contact with you, the Meditation Australia teaching community. It's not necessary to have seen this video. The speakers have, I have, Lisa has. It has been made available on our social media and through various social channels, so it is available for you to watch if you wish to, perhaps after the event. It's for a subscription fee. But it's not contingent upon it. You won't need to have seen it for this panel to have great value or make sense for you today. So I just want to point that out. We may at times refer to Vijamala Birch and some of the ideas that she raises in the video, but we're teasing them out and we're going to talk about them in a bit more depth. And Lisa is also going to be brought into this panel too to ask some really great practical questions around how do we support people coming to meditation classes who might be dealing with pain issues, chronic pain, acute pain, or health issues as well, and illness. So it'll be rich pickings, I'm sure. So that said, I'd like to introduce our fantastic speakers today. to my right, I don't know, can you say this? Camera right, camera left. The lady in red and the gentleman in a dark hoodie that you'll see at the top of the screen. I'll introduce them first for you. This is Joe Dunin and Tony Dunin, and to their left, right, alongside is Helen Perry. So I'll just read out a little bit of information about them, but first I want to wave hello to you and thank you so much for being here, Joe, Tony and Helen.
Hi there.
Hi.
Hi.
So Joe and Tony kindly provided me with a joint bio for you. So this is a bit of some background about them for you. Tony Dunin is an orthopaedic surgeon who is also an MBSR, mindful-based stress reduction teacher. Jo Dunin trained as a registered nurse, however, she's been a professional historian for most of her career. Jo and Tony have been teaching mindfulness meditation to health professionals as well as the broader community for some years. They've both been involved in research into the benefits of mindfulness meditation for patients with osteoarthritis of the hip and the knee. They also both teach at the Melbourne Centre for Mindfulness, and they may be well known to some of you watching today, and if not, I'm introducing them to you right now. So thank you both very much for being here.
Our pleasure.
Thank you.
And Helen Perry is Brisbane-based, and she is a clinical psychologist and adjunct senior lecturer in the Faculty of Medicine and Health at the University of Sydney, a psychotherapist, a trainer, supervisor and researcher, a published author and a health coach. The cornerstones of Helen's orientation are cognitive behavioural therapy, or CBT, compassion-focused therapy, or CFT, mindfulness, meditation and self-practice / self-reflection. And after facing many health issues of her own, Helen speaks from a compassionate insider perspective, especially about the benefits of meditation, healthy eating and movement. Helen's current focus is on the enhancement of health and wellness, particularly in the context of chronic health issues and chronic pain, and you can find out more about Helen's previous work on her LinkedIn profile. Hi Helen, thank you for being here as well.
Hi there. Thanks for having me, Megan.
You're very welcome. So I thought to start off with, it might be useful to just look at some definitions around pain, and I'm consulting the panelists today. We're in agreement that Tony, who is the medical doctor amongst us speakers, might be the right person to ask. So Tony, could I just invite you just to start off this discussion to give us some definitions around what pain is, acute pain and chronic pain, because they are often used interchangeably.
They are. Firstly, I'm not a pain specialist, so I'm a person who treats pain by operating on them, but also talking to them too. The definition of pain by the World Association of the Study of Pain is coming up with a new proposed definition. And that definition is an aversive sensory and emotional experience typically caused by or resembling that caused by actual or potential tissue injury. So notice some of the terms that they're trying to take it away from the biomedical model that there's a stimulus causes pain to be greater than that. It's not very Buddhist though, because they've changed it from unpleasant that you can experience pain but not suffer. So unfortunately, I've been involved in their description of, so that's how it is now. Now, acute pain is a physiological signal. It's a response that we have. Typically, we put our hand on the hot stove and our body reacts. It's a signal to say, take it away, and we do so automatically. So it's adaptive, and we usually know with confidence that that unpleasant stimuli will go quickly, even if there's been significant trauma or injury. And so it's not usually associated with too much of other factors. It is always a signal, it is always subjective, whereas chronic pain in definition is usually pain that lasts longer than 3 or 6 months, caused by either injury, surgery, but it can occur spontaneously. And it's a condition on its own, separate from acute pain as purely a response. And it is, again, multifaceted. It's related to other factors such as our human body and how our body responds to trauma, the psychological makeup, our social situation, and our perception of both our own body as well as the potential cause of pain. So that's where chronic pain is multifaceted. And if you think of the brain and the spinal cord as like electrical wires, and what happens in chronic pain, there are changes that occur within the spinal cord and the brain, which tend to amplify the pain, make us more sensitive to minor stimuli. That tends to cause the pain to just keep going, even though the initial peripheral stimulus, be it in the arm, leg or body, may have either partly resolved or resolved. But somehow the circuitry of the brain gets a mixed message and it continues. I'll leave it at that for the definition. Megan, you're...
Megan?
Beg your pardon. Joe, would you like to add anything to that before I move to Helen to ask if she'd like to add something to that?
No, I think Tony summed it up pretty well. I would say that we know, as he said, it's multifaceted, and how we one of the elements of it that I think is of particular interest to us as meditation teachers is our perception of what our experience is really at the core of how we live with chronic pain, or how we relate to chronic pain. And that perception, it has all sorts of input into it, the causes and conditions of our past history and our past experiences, as well as many other factors. And I'd just say that perspective we have of our experiences, I think at the core of it. But I think Tony...
We will dig into that. Don't you worry. There'll be opportunity to dig into that more today. Helen, is there anything you might like to add to this definition of pain that we're working on?
Ask me. I've always got something to say. So
Good.
stop me if I go over something. You're going to notice that I'm a big one for metaphors. So, and Tony and Joe, we can work with this metaphor maybe later, but the metaphor that I sometimes think of is, it's a bit like, if you take a photograph on your phone and you've got an image on your phone, and you can then go and kind of edit it. So even though if you all looked at it, we'd all see a tree, I can kind of change the color, I can make it brighter or darker or whatever. And that kind of relates for me to what Tony said about the initial acute pain, that people, see it differently, experience it differently. And then with the chronic pain, it's a bit like the cloud. So you kind of upload the photos into the cloud, and let's pretend that's the brain, and I'm not being too physiologically accurate here, but it's kind of in the cloud. And then for a while you might have it on in both places. And then at some point, and obviously we're using pain. So let's just say your hand was amputated, and so the image has actually gone off your phone now, but the person can report that they feel pain in their hand. So it's like the cloud is then, giving some messages or whatever. So sometimes I just use that as a bit of a metaphor for explaining chronic pain, because it can help people to understand that we're not saying it's not there or whatever, but we're saying that perhaps the source is not actually the finger that you cut, 6 months or 12 months ago, that there's perhaps been some interaction with the cloud, with the brain. Anyway, that's just a very simplistic, but quite a metaphor that has been found to be useful.
Thank you very much. I've also, Vidyamala actually talks about chronic pain being experienced daily for more than 3 months. And in the video, and I should have also said at the start, I'm also very grateful to her for that interview, because it is quite an in-depth exploration of pain from her own point of view, and also as somebody who has taught mindfulness-based pain management for many years to people, and helped many people deal with pain through that kind of meditation and attention, quality of attention. I loved what she said in it, actually, where she said two things. One is pain is a process, and I think we will talk about that today. And another one, when she starts off talking about what happened to her as a young person, that pain was like a disruption to her easeful way of life, because often we forget we even have bodies, and the way we're reminded is through some kind of perhaps acute pain or a painful event. Before we look into, the pain is a process side of things and that relational aspect that Joe and Tony were mentioning before, Helen, I might just invite you also, as somebody who has been on their own pain journey, chronic pain journey for most of her life, just to maybe tell people a little bit about that, because you might actually bring that into some of the chat that we have today.
Okay, so I won't tell you my whole long story, but just so that you know how long. I'm 59 now, and I started with septic arthritis at 9 months old. So from the age of 10, I had severe osteoarthritis in my right hip. And then over the course of my life, I've had a lot of problems. I've had 2 hip replacements and have a variety of other chronic illnesses, most of which have some manifestations in pain. So that's kind of my story, and probably for 52 years of my 59, I was in denial. I, was a kind of a high achiever, and I just pushed away, worked as hard as I could, ignored my pain as much as I could, and until I crashed and kind of had to deal with it. So that's been my journey, and then my journey has been probably the last 7 years or so, and it's been a long and windy road. But I'm glad to say that at this point in it, the main benefits of what I've done has been that I have firstly befriended myself, which was not the case before. I've come home to my body, to use the words of Vijamala, in that I've learned to actually live in my body and occupy it, and not kind of push my body away in order to also ignore pain. So befriended myself, befriended my body, and I think ongoing learning to live in a more easeful way with the issues that daily arise for me.
Okay, thank you very much for sharing that. I appreciate it. Back to you, Joe and Tony. Now I'm just going to look at my notes here, because I'd like to quote you correctly in some reflections that we've been swapping between us. You said that between the two of you as MBSR teachers, working with people who have chronic pain, you said our experience of working with people in pain confirmed what is already known but not necessarily understood by doctors, that clinical findings and our experience of pain are not necessarily related. Can you tell us a bit more about that, and also specifically your experience working with people, teaching them MBSR around that?
Do you want to start, Tony?
Would you like me to talk about our research?
A little bit, as it relates to your teaching, absolutely. Yeah.
Okay. So our background was that through the collaboration of the academic departments of psychiatry and orthopaedics at University of Melbourne at the St Vincent's Hospital campus, we did a randomised controlled trial. So it's a level 1 trial looking at people who are about to undergo joint replacement surgery, hip or knee replacements. Now, they're great operations, but there's a significant percentage who are not satisfied with the end result, particularly in knee replacements. So we had one group who was an active control, who had their joint replacement, and the other group, randomised, had MBSR, 8-week course before their joint replacement. And that was a major undertaking to get that going. It was funded by the Australian Research Council, and there were many of us involved in doing the study. But Joe was the main facilitator, as I was, and one psychiatrist. And what we found was that we looked at the results at 12 months after their surgery, 3 months and 12 months. And at 12 months, we found that the group that had the MBSR course had meaningful and clinically significant improvement in their pain and function compared with the control group. This is a unique study. There's been nothing else done like it before. There have been other studies looking at physiotherapy before surgery and other treatment modalities without any difference being shown to be the outcome. And in fact, in surgery in general, there's been no randomised trials using meditation or MBSR. So it took a lot of hard work to get there, and we had it published in Complementary Therapies in Medicine last year. What was interesting was that there were 20 patients in the treatment group who did not go ahead with their joint replacement surgery.
Wow.
And of that 20, 14 did so because their pain had improved so much they didn't need the joint replacement. Many of them said that they didn't need the analgesics. Some of them were on narcotics. They came off them and were generally very happy with things as they were. So they had a better acceptance of their situation and not needing it. So it was groundbreaking surgery, research, and we were really pleased that there is some evidence that we can take to our colleagues to say it's not just about the biomedical model in joint replacement surgery. The other thing that you touch in your question is we know that we see many patients who come in with an x-ray that looks really bad, bone on bone, bone worn away, and you ask them, you got much pain? And some will say, no. And there are other patients who have got mild x-ray changes and severe pain. There's not a strong correlation between what's happening in the peripheral part of the body and how we experience pain.
So what do you put that down to then as meditation teachers? And I'll get to you in a moment too, Helen. Like, are you saying that mindfulness meditation relates to what we were talking about before, that relational idea of how we relate and perceive pain?
I might let Jo answer that question.
Mm-hmm.
Absolutely. I would say that in my experience of teaching most of the patients in this study, and through my own experience of pain in my life, having had pretty major surgery for cancer and experiencing quite a bit of pain during that time, and subsequently, which I can talk a little bit more about later, but certainly those patients in the study came in, and this is a really important thing for meditation teachers, because all of the people that you teach self-select. They come to be taught meditation because they're interested. Whereas this was a group of people who were attending outpatient clinic in a public hospital, who had severe enough osteoarthritis to be put on a waiting list for a joint replacement. And then they were approached by someone saying, would you be willing to participate in this trial? And it was actually quite hard to recruit people. There was a lot of resistance, but we did manage to get the numbers. But what's significant about these people is they had no particular interest in the idea of meditation. Many of them had no idea what it was about. And the other really important thing to remember is that many of them had significant social and medical complexities around their life. Most of them had pretty significant social disadvantage, complex dynamics in their family setup. Many were very socially isolated, and many of them had quite significant comorbidities in terms of their health issues. And yet, even those people, when offered the opportunity to learn to meditate, went from being quite disabled and suffering significantly, and stating at the outset of the 8 weeks that they had pretty significant pain. Many of them, as Tony said, on opioid analgesics. And I can still remember a woman coming back after 2 weeks and saying, I've stopped the opioids, I take Panadol occasionally. And it was pretty clear that what was happening was that the amplification of their pain that was being generated by the habitual thoughts and feelings that go around in relation to the unpleasant experience, unpleasant sensations that are being caused, or that are arising, that they're experiencing as pain. That relationship with that was changing. They were starting to have a different way of viewing this, and the degree to which that pain was being amplified to the point where they might need an opioid analgesic was starting to settle down. And that, to me, was a pretty clear, and yet their radiological findings weren't changing. Their osteoarthritis in their hip and their knee was still as severe as it was at the beginning as it was at the end, even for the ones who didn't go ahead with their surgery. So as Tony said, it's not so much about the clinical findings, but there is a change in relationship between to use Helen's metaphor of, what's happening in the cloud, what's happening up here in the brain, and what's happening somewhere else in the body, and how those two are communicating with one another, and what's happening in that relationship there.
The relational aspect is key in mindfulness-based anything, isn't it? Really,
Yeah.
that goes to the heart of it. And look, I should point out too, we're not trying to say that mindfulness meditation solves anything by itself, but it certainly can help reduce suffering. Thank you very much, Jo, for that. And we'll pick up some more stuff, especially around that isolation in a moment. I'm keeping an eye on time too, Lisa. I've still got time for a few more questions before I hand to you. Yeah? Yep. I saw you nod your head. Helen, you're also, you've done a little bit of breathworks teacher training, but you also came to this idea of mindfulness-based pain management through that particular program. So you've had a real insider perspective on that relational side, that process side of what pain is. So maybe you can give us a bit of an insight into that, and also how you might translate that into your own therapeutic professional practice.
Okay. So, well, just in terms of the relationship to the pain, I'll talk about that from a less physiological point of view, as that's been covered by Jo and Tony. But I think as you change your relationship to the pain in terms of kind of turning towards it, approaching it, versus resisting it and pushing it away, it changes also in your perspective of how you see it and how you perceive it, and then mostly in terms of how you respond to it. So once you turn towards it and actually look it in the face, the monster that was kind of out there, and suddenly when you look at it, it seems like something that you can then relate to in a different way. So it provides you then with some choices about what you do. So for example, if I'm pushing away pain and I'm just trying to work and I'm sitting down and my back's hurting and everything, and if I then turn towards it and say, what's going on in my body? Do a bit of a body scan or something and say, oh, it's my back. That's why I'm feeling so kind of agitated or whatever. Then I can decide, do I need to just lie down on the floor, put my legs up a little bit, do a bit of meditation? Do I need some strong, do I need to continue with this job right away? Do I need to take some strong painkillers? Or could I just take a bit of Panadol, lie down and meditate for 15 minutes, maybe stand up at my desk, which you'll see I'm doing right now. So I can then make some choices about what I do. And by doing that, as I say, it changes your whole relationship to the pain. And then I might then say, take a break for 10 or 15 minutes and then come back to what I'm doing and be able to continue. Whereas if I push against it and leave it until it's too late, then I might need to take a larger dose of painkillers. So I think it's, obviously the physiological and damping down of that nervous system is absolutely paramount, but it's also about that ongoing moment by moment relationship to, and using your breath, using breath awareness. Oh, my breath's there. What's going on in my body? Whatever. Yeah. And then you asked about how that would relate to my professional. Can you just rephrase that a little bit for me?
Well, just how that insight that you have within your own personal experience may not, I'm not presuming it does, but might translate to your own professional practice as a clinical psychologist, or you're also someone like Tony and Jo do a lot of teaching to medical professionals. You also do a bit of training around this with people like physiotherapists and things. So how that might relate to or translate to how you, in that therapeutic or teaching context.
Okay. I think the number one is not to ever assume that I know what the other person's experiencing. So always to get their little idiosyncratic, fingerprint of what their pain looks like, how far they are in the journey, meet them where they're at, and then take them from there. And then secondly, I think, when you ask the question about working with professionals, I'll use a metaphor because I'm a metaphorical type. I will say to people, you're coming in with your medical hat on. Would it be okay if you just left that at the door? And I'm going to see whether I can help you create a new hat. I'm not saying I don't ever want you to put the other hat on. In fact, I'm going to really invite you to bring that hat back into the room later. But for now, and see whether we can use a meditative or a mindfulness approach to your pain, and see if we can kind of create another hat about how you relate to pain other than a medical model about, there's a pain, therefore we need treatment or whatever, so that there's kind of more self-efficacy or whatever, or advocacy, you know, from yourself. And then I invite them to then bring their own hat back, and then, you know, we can use both. And in fact, then we can really draw on their wisdom. But for a while, it's safer if they leave the medical hat. Otherwise, they're constantly in that mode, and it's very difficult for them to kind of, you know, switch into another mode. Anyway, that's just before I use it in all my teaching for things when I'm teaching a new therapy to people or something.
Yeah, thank you. Tony and Joe, maybe you can respond to that, because I think it's at St Vincent's Hospital in Melbourne, you teach a bit of meditational and mindfulness awareness to medical professionals such as doctors. And I know that, Tony, that you think that maybe we should develop a new language around how we talk about pain.
Well, I think so. Unfortunately, doctors by their nature are somewhat resistant to go near mindfulness and meditation because of shame, because they don't want to be perceived as being vulnerable. It may affect their ability to get the next job if they're a trainee doctor. What will the others think about them? So we've tried to provide a safe environment where doctors come along to do a modified MBSR course called Mindfulness in Medicine. And the doctors that have come have found that incredibly helpful, not only in their personal life, but in their professional life. And I can say that now, that for me, not only has it helped me personally, but my ability to relate to patients, to be an incredibly deep, thoughtful listener is so important, as well as in my surgery. I think that my ability to operate, to be in the moment, to be aware of what's going on has changed so much. Difficulty is that there's still a lot of concern amongst the general medical community that it's soft medicine, that there are other priorities which are high, we don't have enough time. The medical schools are gradually starting to see that it is important. Self-care, and particularly through mindfulness, is important, because we know that the rate of burnout amongst doctors is going up, and in the States it's now 54%. And whilst that is distressing for the individual doctor, it has an impact on patient care. The number of medical or surgical errors goes up if you're burnt out. So
yeah, and I'd add to that the two things. One is that when doctors are burnt out, one of their ways of managing that, and one of the drivers of that, is that they actually are pushing the patient away. They're finding the patient overloading. So you can imagine a patient arrives into a consulting room and they're expressing they've got pain, and this doctor's going, whoa, you know, I can't deal with this. I'm overloaded and it's too much for me. So there's the major effect on how they are able to approach that person. And then the other side of that is that one of the reasons they're not able to cope with that patient who's presenting with pain is that their care for themselves, their compassion for themselves is at such a low level that their capacity to show sort of empathic connection and compassion to the patient is extremely low. And as I say over and over again, you cannot care for others compassionately unless you can do that for yourself. So there's a really big problem there in health professionals in how they approach patients with pain, and how they even speak to patients about pain, rather than blaming patients or saying, well, you know, you just got to get up and do this, or go and do that, or do more of this or less of that. Actually beginning by just showing some compassion to that patient. This must be really hard for you right now.
Yeah.
Just acknowledging that and taking a moment to actually start from that place, rather than going into all the clinical and fixing mode. Because the other thing is that doctors will want to do is, when they're presented with a patient, particularly a patient with chronic pain, is they want to fix them. And there's two ways they want to fix them. One is give them lots more drugs, and we know the disaster that's created, or they want to operate on them and get them out of the room. And when they operate on them, they're unconscious, so they don't have to talk to them and they don't have to relate to them. So there's a really important thing about recognising that need to fix, and recognising that my role is not to fix, it's to heal.
And maybe to listen as well for a bit.
Because healing
you heal through listening.
through listening.
Yeah.
Because the healing begins the moment the doctor walks into the room, how they even are as they walk into in themselves.
Yeah.
And how compassionate they are to themselves will be very much on show to that patient. So
Yeah. And that relates very much to something Vidyamala actually does say at the end of the video, which is about giving patients agency. They know their bodies best too.
Exactly.
But look, you both mentioned the C word, compassion. So let's get a little bit more from you there, and then I'll hand over to Lisa to ask some questions on behalf of meditation teaching cohort. Maybe we'll start with you again, Joe. You mentioned compassion. Tell me about the role compassion, the benefits perhaps that can come to people dealing with chronic pain when they start to practice self-compassion, because I know you've done some mindful self-compassion training, as has Helen.
Yeah.
Tell us a little bit about that.
I think one of the things that happens with us when we have difficult experiences, whether it's chronic pain or other difficult experiences, is that we get often have a very harsh internal critical voice firing away pretty much all the time, whether things are bad or not, or whether things are difficult or not. That critical voice is often working away there in the background all the time. Then when we have a difficult experience or an ongoing chronic experience where we're really suffering, that critic can ramp up even further. This shouldn't be happening. I should be able to manage this. I should be on top of this. Why is this happening to me? All sorts of very harsh tone of voice is firing away there, amplifying our suffering that's already there. So if we can turn towards ourselves, notice that critic and bring some kindness and compassion to that, as though it were a dear friend, imagining ourselves to be like someone who's come to us and said, look, I'm really suffering right now. We don't say, well, get on with it. We say, that must be
Get over it.
Get over it. We actually offer them a great deal of kindness and gentleness, and this is what compassion for the self looks like. So when we start to, instead of just beating ourselves up more, actually able to turn to ourselves and say, this is really hard right now. Acknowledge the difficulty we're experiencing first, and I can bring kindness and care to myself right now. I can be real. I don't need to give lots of space to that very critical voice. I can let that go. I can give that, not shut it down. I can just allow it to sort of be there, but I can allow that kind, caring and compassionate, tender part of ourselves to actually be given space as well. And in time, the harsh critical voice gets quieter and quieter. And in that flood of compassion and care for ourselves, we get a shift in the brain, and Tony's better at explaining this than I am, but we actually know that when we show compassion to ourselves, certain parts of the brain light up. When we're suffering and in pain, there are other areas of the brain are lighting up. But that compassion area of the brain, when that lights up, the suffering part actually starts to ramp down. So there's an actual physiological explanation for what's going on here. But it is a really important part of actually taking care of ourselves with kindness, with care.
Yeah, softening.
Softening, allowing, and also allowing what just being, this is how it is. This is where I am right now, and I can bring kindness to myself in this.
It's very, very useful. Yeah.
I'd just comment that when Jo was talking then, you may have noticed what she was doing with her body, with her hands, but when she was talking about that self-compassion, her hand was on her heart, and then later she moved, when it's harsh, it's up in the brain. And it was interesting that there's been an exciting time of research, largely done by Richie Davidson of Wisconsin, who's been a neuroscientist. He's done a lot of work with the Dalai Lama, and they've put Tibetan monks in these functional MRIs, and as well as doing EEG studies. And the monks, didn't have much scientific background, and they were laughing. And they said, "Why are you all laughing?" He said, "You're putting all the electrodes up here. It's here. This is where we have a hard mind, don't we?"
I love it. Yeah, exactly. I know, it's amazing, isn't it? The difference, the cultural, just the chink of light that shines slightly, refracts slightly differently culturally.
Yeah.
With that. I'm just aware of the time, but thank you so much, Joe and Tony. I'll just hand it to Helen. You practice compassion-focused therapy too, Helen, and you've worked with Paul Gilbert around this. What's your take on compassion and the benefits of that around managing pain?
Well, I mean, everything that Joe and Tony have said, I absolutely, go along with. That's and that relates a lot to the self-compassion. So I'm not going to review all that. Although I would actually like to ask for a moment if everyone just puts their hand on their heart, just for a second. Bring your attention to your own heart, to your own, how you're feeling in your chair right now, what's going on for you. And then just a little smile on your face, not a weird one, just a little tiny one. Notice the difference. Do you see any difference? That's all it takes sometimes. It's just that gentleness, just that little, kindness to yourself. Okay. So, but then I'll talk more from the compassion-focused therapy side rather than the self-compassion, because I think Joe and Tony covered it as much as they could in the little time. But I think one of the important things to remember is that compassion is not a soft, squishy, kind of pathetic emotion. It's actually an emotion of great courage and great wisdom. And that's what it brings to the body. If you can bring compassion to your own body and then also to the bodies of others. So talking to meditation teachers here. And then I like Paul Gilbert's way, when you talk about the self-critic, he talks about compassionate self-correction. Because not all that we're doing, so say, for example, with me, all that I was doing with my body was not all that wise, working, 16 hours a day, et cetera, et cetera. But instead of then, being harsh on myself about what I'm doing, etc., to have a compassionate, self-corrective kind of approach to say, okay, so what could I do? But doing it from a heart of compassion, not a heart of, you're bad, so not that sort of self-critical approach. And then just one last thing that I wanted to point out, which is that when people are in a lot of pain and suffering, and we'll probably talk a little bit more about the definitions, the differences between those two. When we bring compassion to that, what can happen is an enormous outpouring of sadness, shame, grief. And so just to alert meditation teachers that not everybody will go, oh, wow, that was amazing. I felt so much better. Some people, everyone come out of the meditation and somebody will be really grieving or sad because they're aware then of how harsh they've been or how much they've lost in their lives as a result of their condition or whatever. So just an awareness around that. I mean, I could say so much more.
No, that's an incredibly important point, Helen.
Pointers, particularly addressed towards the meditation teachers and their practice.
Thank you very much. Thanks so much for pointing that out too. I really appreciate it. Lisa Ford, your time to unmute, your time to shine, your time to ask some questions. Thank you for being so patient.
Everyone, thanks Joe, Tony and Helen for what you've shared so far. There's some really fundamental concepts there that I think meditation teachers probably are already probably different to doctors in that respect. They're already practicing meditation, already practicing self-care, self-compassion. And so their concerns may be, rather than being resistant, their concerns may be about, will I be able to support my students in the way that I want to be able to support them? Will I be able to handle what comes up for them? Will I be able to, I don't want to do any harm. That's going to be their worry and their concern. So my first question is, you've talked about MBSR and in the interview, Vijamala talks about the body scan. And I wonder from your point of view and from perhaps especially Joe and Tony, who've been doing a lot more, a bit of teaching in this area, what sort of techniques do you feel work best when supporting people with pain?
I'll answer one bit first. I'll let Joe talk about the body scan maybe. But in MBSR, because I know some people here are MBSR teachers, in that you're aware that you spend quite a bit of time doing movement practice, standing or lying. with our course, we got together to work out how we're going to manage these people who are severely disabled, some using walking aids, and how we would modify the movement practice to accommodate them so they didn't feel shame, they didn't experience a significant amplification of their pain. So we did a lot of the practices either lying or sitting, and so that they felt safe. And then the recorded meditations that they took home with them, initially I think they were they on this is the times before USBs, they actually got a disc, and they would play them at home, so they felt safe doing that particular form of movement practice. And it was interesting, it was a really rich experience, the mindful inquiry that came up, that because they are suffering so much, they had a lot to discuss, and they felt, because they're in a group, that they weren't so isolated. They have a sense, oh, you feel this too. So that was very powerful and therapeutic for them.
Yeah, I think in terms of how the tips I would give is that, first of all, I'd say that even if you're a meditation teacher, having someone who might come into your class to teach you, who puts their hand up for having quite severe chronic pain, that can immediately set off an alarm bell. Oh, am I outside my comfort zone? And that can still create some resistance, no matter how much you embody compassion for yourself and embody a mindful and steady mind. That can still be quite triggering. And that, as you said, Lisa, that fear around how can I help this person and do no harm. So to sort of come off what Tony was saying, one of the things I learned very quickly with these patients, as he said, who were pretty severely disabled, many of them were morbidly obese, so their capacity to move at all was often very limited. There was a lot of shame there. They needed a lot of great care in being present with them in a really kind way. So the thing that first I did was really emphasise very strongly right from the beginning that this is a program that you're being brought into to help you and to couch it in terms that offered a great deal of care and compassion and kindness straight away. So this wasn't a boot, this is not a boot camp. We're not going to be getting you to do something that you're not at ease with. This is something to support you, and to go to Helen's, mentioning Paul Gilbert, that Paul Gilbert uses that model of emotional regulation, that this is about self-soothing. This is about how we're going to help you find ways that will, help you soothe the discomfort you're in first. So I think that reassuring beginning. And then the other thing that Tony alluded to there was modifying things for them in ways where if they can't sit for very long, giving them permission to get up and move around if they need to. Very simple things like that for people, particularly with severe back pain. If you need to get up and walk around, that's absolutely fine. So giving people permission to move or sit or find ways of being in their bodies that are comfortable for them during the sessions. And then also the other thing with the body scan, starting up right from the beginning, saying we're not trying to achieve a particular state or way of being. This practice is not about getting somewhere. We're not even trying to feel relaxed or pain-free or any of those things. This is simply about noticing what's there and being with things as they are and just seeing how that unfolds. So again, not getting them into a situation where they're thinking, oh my goodness, if at the end of this body scan I don't feel $1 million, I've failed and I might as well give up. So that's really important, that reassurance that we're not trying to achieve any particular outcome here. So that lets them off the hook in terms of their own expectations they're driving perhaps for themselves.
And it also lets the meditation teacher off the hook, doesn't it?
Absolutely, absolutely. And then, I mean, I don't know how much more you want me to say, but in terms of then how you are with when people say, you know, I'm just in pain all the time, and how you would engage in a discussion about that. But you might want to leave that for the moment. But certainly in terms of how you would approach a body scan, the other thing I would say is how you invite people to do the body scan. They might, and this is another thing that I learned very quickly at St V's, was that a lot of these patients couldn't get down on the floor, not because they were in pain, but because they physically, morbid obesity made it extremely difficult for them to do it. And there was huge shame around that. So being very sensitive to the language you use around choosing a position that will feel right for you. It might be sitting in a chair, it might be lying on the floor, it might be standing. Just choose what feels right for you and feels within your range of capacity right now. So giving people lots of permission and giving them lots of reassurance that you're not going to shame them and you're not going to demand a lot of them, and that there's no particular outcome that you're looking for, I think, are the key probably takeaways there on that.
Thank you, Jo, that you've answered quite a few things that have questions that have come up for me. So that's terrific. Thank you. It sounds like love, gentleness, acceptance and non-judgment are the main keys here.
Absolutely.
Yeah, thank you very much. Helen, did you have something you'd like to add there?
Again, Jo's done a great job there. I'll just say one thing, and again, I suppose this is something for the teachers as they go into the room, but I mean, our intention as meditation teachers is always to be helpful, not harmful. And so if we go in with that kind of compassionate approach and even say that to the people in the group, you know, my intention today is really to be helpful to you and obviously not to be harmful. So, you know, I haven't got time to find out exactly where everybody's at today, but if at any moment you feel that something that we're doing doesn't feel comfortable for you, or you feel like it's actually harming you in some way, like you're becoming too upset and that's going to make it too hard for you to stay in the room, I ask you to just, as we say in self-compassion, just close down a little bit. So maybe perhaps, you know, so move yourself emotionally, perhaps do something a little bit different to distract yourself for a moment, but feel free to, you know, pull out of the little meditation that we're doing or whatever, or the practice that we're doing if it's becoming too difficult for you. I mean, obviously we're not trying for people to avoid all pain, because we actually want them to notice the comings and goings. Mm-hmm. But whether you're working with people who are in emotional pain or physical pain, we know that doing a lot of these practices can actually bring up, you know, so for example, let's just say, you know, I'll give you two little examples that, and hopefully this will cover some of the other points that we need to make. But let's just say you have a soldier who's got severe PTSD and you ask him to do a body scan. And as he's scanning down through his body, he suddenly realizes, oh my gosh, my heart's racing, you know, my mind's racing. And his sense of threat is severely elevated. And so his kind of anxiety and agitation can become quite severe. That's not what we're looking for. So, and then equally, the person who's in severe pain, if they have got themselves in a position where, as Jo said, maybe their shame's increased because of the way they're sitting, or someone's standing behind them and they suddenly become aware of what that person's looking at or something, or whatever, or their pain's amplified because of the, you know, because they notice, because they're aware. Because as you bring awareness to something, it's like you put a microscope, you know, like a big microscope, a big magnifying glass over the top of it. So if you bring awareness to my shoulder, which is really painful in your body scan, all of a sudden that shoulder blows up in my mind. And that then again can increase that sense of threat. Oh my gosh, my shoulder's really bad. I didn't realize it was this bad. And the mind goes off racing down that channel. So just being aware that sometimes as we're bringing awareness to things, we can actually ramp up that level of threat. I'm not again saying we shouldn't ever do that, but just giving people that information as well beforehand, that this is what might happen. And if that happens for you, feel free to either indicate to me that you're struggling or whatever, or otherwise, you know, give them some ways, you know, that they can kind of opt out. Like if they've got their eyes closed, open your eyes, pop your eyes open, you know, roll on your side, do something different to kind of bring you out of that if you feel you need to. So just giving people permission to get up and move around, as Joe said, they don't necessarily even have to tell anybody what's going on, but that might just break them out of that kind of amplified threat situation, which can happen. Anyway, so I mean, look, that's the worst case scenario. So I'm giving that to you because you're saying that's what people might be afraid of. And there's maybe some ways that people can help, can work with that.
That's fantastic. Thank you, Helen. It's really great to be able to communicate expectations to your group, and also giving them permission to listen to their own bodies and be the master of their own experience, so that they don't feel out of control in a situation where feeling out of control is something they probably feel a lot. Yeah, thank you very much. That's terrific. And I'm wondering, you mentioned something before about not knowing, what people's individual situations are when they come into your group. Would you, before beginning group work, survey or speak to people individually about their particular situation? And once you're aware of their particular needs, how do you manage those differing needs within the one group where they may be quite diverse?
Okay. So look, my background as a clinical psychologist, I would always prefer to do a bit of an individual assessment before I do any kind of group work. And the reasons for that are multiple, but just a couple of them is, if somebody is in real distress, either emotionally or physically, perhaps a group isn't the ideal setting for them. So it allows me the opportunity to say, look, sounds like, you really distressed, and what about, we could possibly do some individual meditation sessions, see how you go with it so that you don't feel, that bad in the group. So that would just give them some options. So that would always be my preference. But obviously I do go into groups where I sometimes I do the meditation side of a balance group with a physiotherapist, and I don't always know what's going on with people. But then I make sure that I just go gently with things. And as we said before, give lots of options about how you can come out of it, how everybody's different, how everybody's experience, everybody's at a different place. So just giving all those kind of landmarks for people to know that I'm not expecting everyone to have the same experience. And like Joe said, I'm not expecting a particular outcome. But that's how I would manage it in a group, would be to just let them know everyone's going to have a different experience, and everybody's body's different. And that's absolutely fine. So, yeah.
That's beautiful. Thank you, Helen. That's
and
really
just to add to that, we always interview our clients before they do the course. Mm-hmm. So we get a feel for where they're at, what their belief systems are, and if they've got chronic pain, just how it does affect them, and then talking to them about how we will manage that during the program.
And like Helen said, there will be times when I'll advise people that this may not be the best time to come into a group. They may need some one-on-one assistance, just as Helen said, before they come into a group. They might be able to come into it down the line, or they might never be able to for a variety of reasons, and a different modality might be much more appropriate for them.
Yeah, thank you.
So we screen, we do really pay close attention to, is this the right thing for this person right now, rather than just saying, well, we know meditation helps everyone, so, on you come. It doesn't, it's not, we need to be very careful about that, and really our duty of care to people coming in is that we, as Helen said, we don't do harm.
Yeah, definitely. And so on that topic, Joe, of not doing harm, is there something that you would say to meditation teachers that they should avoid doing when they're running their groups and they're aware that there are people suffering from pain in their groups?
I think what I would do is just confirm what I've already said in terms of always giving, when you are about to do any sort of a practice, give people that permission, as Helen said, to pull back at any time. I think that's, if you've got people in a group, and when I've had recently, not just during the research study, but if at any point this is too much for you, you can step back in literally or figuratively, metaphorically, you can take a step back from this and know that you are the one making the decision here. I'm here. I think the important thing is that your language is invitational, not directive. Really, really important that it's always invitational, and learning that language of always inviting. So turning towards ourselves right now, paying attention to where we're noticing X and Y or whatever, rather than now do this, now do that, now do that. That invitational language is really, really important. And if you set that up with saying beforehand that if this isn't anything I invite you to do in the next little while, doesn't feel right for you, or becomes unbearable, or not manageable for you, step back. So giving people a space and using language that is strongly invitational, not directive, I think is really important there.
And also when we start the movement practices, we make a point that some of this, use your own body's wisdom to tell you what you can and cannot do. But we also know the power of mirror neurons. So imagining your own body doing the movement while you're at rest, and it still achieves quite a bit.
That's fantastic, Tony. I think that's a great point for meditation teachers to remember that they might not have otherwise thought of.
Yeah, it is a good one.
Yeah. So I've just got a final question or a final point that for you to speak to, and perhaps I'll direct this one to Helen next. What really intrigued me in the exploration of this topic is that the wisdom here goes beyond people suffering from pain. And I know there are times when my body's suffering because I'm working too hard or not getting enough sleep or rest, or I put band-aids on things that need more care and attention. And I think as human beings, with our human natures, we're apt to do that, So just this whole discussion and the Vijamala interview has really prompted me to revisit my own relationship with my body. Here we're talking about a relationship with pain, but what about all of us in our relationship with our body? Can this wisdom also be applied to everyday life, everyday suffering, everyday situations?
Absolutely, Lisa. That's my short answer. And I'm just so glad to hear that you are taking it on board for yourself, because we don't have to be in acute or chronic pain for this to be an issue. I mean, most people that you speak to have migraines now and again, or have, menstruation problems, have cramps or whatever. So, and all of us are experiencing pain in one way or another at different levels at any time, whether it's, sort of pain because of emotional stuff, because of conflict in the home, etc., etc. So I think all of these principles do apply. It's just the relative level of it. And I love Vijamala's thing, that all human beings, what we all want to, we don't want to suffer. We don't want to be in pain. We don't want our families to be, and we want to be happy. And so, learning to kind of manage, sort of balance that whole thing out, and not pushing away pain and not clinging on and grasping onto happiness is, so it's the last thing, but actually learning to kind of live with what we call equanimity. I think most of you will be familiar with the word, but learning to kind of accept those two things. And then in terms of my own body and myself, I've kind of ended up developing my kind of pillars of health, but they're also my pillars of chronic, managing my chronic pain and my chronic illnesses and pain when it comes and goes. And they're just a set of, behaviors. There's no blooming neuroscience. Well, there is a lot of neuroscience actually behind it, but just things about my mind, my body, my emotions, and my mind. So managing all of those things. And, a lot of them are not amazing, but using, for example, so managing my mind, managing my pain with my mind. But for example, one thing, doing meditation practices. And then using the various things, the connection meditations, the anchor, the breathing anchor, the body scan, etc. Connection meditations when I feel isolated or feel alone and feel like nobody understands me, or think, oh, all my colleagues think I'm, whatever, because I'm not practicing at this level anymore or whatever. But, then using a bit of self-compassion or whatever. So, so I've kind of developed those. But as you say, if I put those out and said to you, Lisa, here's my pillars of health, you probably wouldn't look at them and go, oh, those are for managing chronic pain. You'd probably say, oh, that's exactly what I'd like to be doing across my life for my health.
Yeah.
So, yeah.
It's a whole lifestyle, really, isn't it? Yeah.
Mm-hmm.
Jo and Tony?
I just want to share a bit of my own experience, having had cancer and having had pretty major surgery which left me feeling very disconnected from my body and feeling as though this wasn't my body anymore, and having and noticing while well after the pain had gone, but still having this sense of really not wanting to be in this body at all. And I think what the meditation practice has done is allowed me to bring great compassion to myself, and to use that term that Vidyamala uses, is come home to this body, not the one I had before, but to this body right now, and with acceptance, with kindness and compassion and care. And I think that has been just taking off my meditation teacher's hat and putting on the hat of Joe, who's had cancer. That has been hugely life-changing for me, in terms of letting go of this feeling of this is a body walking around that isn't mine, and befriending it, befriending the body I have now, and letting go of the one, grieving for and letting go of the one I no longer have.
Yes, and I imagine that grief would be a part of that, a big part of that.
And two things I'd say is with patients, realising that they're, as I think Helen said, having agency is important. So your body has the ability to heal itself. I might help in the way by adding a bit of surgery, but you can enhance your recovery by being mindful and being and experiencing self-love and self-care. So that's really helpful. The other thing, though, I'd like to touch on is gratitude for the body, for the simple things that it can do. Everyday things that we may get enjoyment out of: walking, swimming, just the simple things. Seeing, being aware, beautiful blue sky, clouds in the sun. I can see those. And saying, isn't that wonderful? Really simple things. And that gratitude is also really life-enhancing as well.
Thank you very much. And thank you to all three of you for that deep personal sharing. That was very enriching and really helpful. Okay, well, I think we'll now move into our breakout rooms. I'm going to assign all the attendees to some breakout rooms. You'll get an invitation that comes up on your screen asking you to join, and I'll just ask that the panellists don't join, and that in small groups you'll be able to debrief amongst yourselves and chat about what we've discussed, and perhaps also see if nominate one person as a spokesperson for each group, and perhaps ask a question to the panel. We may not get time to go around to all the questions, but
yeah.
Right. Yeah.
Oh, sorry, Lisa, to interrupt you. I was just going to say, yeah, look, if there are some burning questions that don't get answered, I'll provide my email address at the end of this panel today. Email them to me and we'll see what we can do about getting somebody to address them or point you in the right direction. And I'd also really like to, if I may, just say thank you very much to the panellists for sharing all that. There's some absolutely amazing, great gems there, and we're very lucky to have you and hear your perspective. So thank you for your time today speaking.
Thank you.
Thank you.
Great. So I will set up the rooms now. While I'm doing that, you might like to just have a little stretch.
Self-care, everybody.
For a little while.
Water, loo break.
I'll now invite you in when you're ready. Thanks, everyone.
So, Lisa, we have to choose groups now, and
Yes.
the people who have been nominated to ask a question can unmute and put their video on.
Great.
Yes.
So if you wouldn't mind just writing your question and your name in the group chat area, and then we can pull out some questions to ask Helen, Joe and Tony. And in the meantime, I did ask Helen, Joe and Tony, whilst you're all in your breakout rooms, for any resources that we might point everyone to in order to help them with their own understanding, but also to be able to point their students to. So Helen, you had a few books. Would you mind just showing us what you had?
Yes, I've got a couple in my hand, and I know Megan's got some that supplement them. So Vidyamala Birch, who the video you would have got the video link from Megan. So Mindfulness for Health. That's a brilliant book. It's by Vidyamala and Danny Birch. Sorry,
Danny Penman.
Vidyamala Birch and Danny Penman. Sorry, getting a bit late.
That's all right.
And then this book, Living Well with Pain and Illness, which is also by Vidyamala. And it's an earlier book than the Mindfulness for Pain. And then this little book, which is also one that's put out by Breathworks, but that's a nice little one for, that because it's cheap and cheerful, and well, when I say cheap and cheerful, it is a cheapish book. But it's also like really simple, got little diagrams, explains a lot of the stuff that one would want to know. It's more for mindfulness for health, but it covers a lot of the same principles. And then just one more to add would probably be, if you were talking about emotional pain, possibly Paul Gilbert's book, one of his first books. I mean, he's got lots of later books on compassionate mind and things which are wonderful, but one of his fantastic books is Compassion-Focused Therapy for Depression. So that's quite a good one. But obviously there's lots, John covered, the ones by, Anyway, I'll stop there.
That's terrific. Thanks so much, Helen. Joe, you had a book as well, I think.
Yes,
Megan too.
This is also Danny Penman and Mark Williams, Mindfulness, Finding Peace in a Frantic World, which again is, generalised for stress and anxiety. So that would include emotional pain as well as also some really helpful approaches to physical pain in a more general sense. And I agree with Helen very much. The books of Vidyamala's, I think you've got some fantastic resources specifically for pain.
Terrific.
And this is the, if just in case you haven't seen it, this is the one we were talking about, self-compassion. This is the book by Kristen Neff, who's one of the co-architects of the Mindful Self-Compassion course that's come out of the States, and Chris Germer is the other architect, and that's his book there. And just relating to you guys talking about compassion, self-compassion earlier, they're two great books as well.
Thanks very much for that. That's really helpful. There's been so much rich information for everyone today. I'm looking at the chat box, and I don't know if I'm missing something, but I haven't seen any questions from the groups. We must be very thorough at covering everything.
But I think we've got the group representatives in front of us who are unmuted and taken their videos off, so you can just point to whoever you like, Lisa.
To go first, can I see your hand up?
Oh.
Fiona.
Yeah, hello everyone. Thank you so much. Just very, very interesting and extremely helpful. I have to be honest, and I sort of did monopolise the conversation a little bit in our group. I am also a nurse, but a palliative care nurse for the last 6 years, living and working in the Kimberley region. Just one of the things that has come up, and this again is sort of anecdotally, is that one of the experiences that I've noticed is that for people towards end of life, how much existential distress impacts upon physical pain, and we find that extremely challenging to manage. One of a question actually that I did raise with a psychologist was around meditation and people who are also suffering a chronic condition, perhaps, which is related to long-standing emotional pain that's not being relieved. And her comment was that she felt that these patients were not ready for meditation, that until we actually dealt with the existential stuff or the emotional pain, that they may not be ready to actually take on, or it may be too much for them. So I just would love to have your thoughts about that.
Helen, would you like to start addressing that one?
Sure. It's always a tricky one, because I think my approach is always to look at the individual and to do a bit of an assessment and see what's going on. And because I would almost be loath to not let some of these people have the access to these wonderful resources. And if you look at the self-compassion, work with Chris Germer and Kristen Neff, and even compassion-focused therapy by Paul Gilbert. You know, in fact, compassion-focused therapy is probably the best example. It's developed for people who have huge levels of shame and self-disgust and anger and anxiety and all of those sorts of things. And while you wouldn't necessarily put them straight into a group, using some of these approaches to people with big pain and trauma histories and stuff is not necessarily an unhelpful thing. Obviously, and perhaps maybe some referral on to a therapist for a while and then coming back into a group might be useful, or referring them to a self-compassion, meditation group. And I think, if you look at my personal journey and experience with this I was teaching people these things 15 years ago. That was the first time I went to a kind of and I remember going to the conference and thinking, oh my gosh, why are we chewing raisins? This is ridiculous. This is bizarre, whatever. And it was, so that was the beginning. And then my GP saying you should meditate, and me saying, no, I don't want to do that. Knock my head against a wall rather than do that. And then going on a self-compassion, retreat, and then going on this and going on that. And many, 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 many workshops and individual sessions with, mindfulness teachers or meditation teachers. And I've kind of, journeyed through that. But gosh, I would find it difficult to just say, no, those people can never have it. But that psychologist may have had some points of reference that I don't have right now in saying that. But I think it's a great question, Fiona. But I think there is each person's little thumbprint of their experience. And how you can support them. Yeah.
I'd like to add to that. I completely agree with Helen on that, but I'd also add that my experience, and I have to be very careful in choosing my words here, is that very often, particularly in the health sector, that there is a lot of resistance and there's a perception that this is somehow exposing patients to something that is going to cause them pain. And what they don't understand is that we can offer very gentle, even quite brief practices. Might be just 5 minutes of just paying attention to the breath, nothing more and nothing less. There are all sorts of ways in which we can offer meditation that we're not going to, I would say, clearly you're probably not going to invite people into an 8-week MBSR course. I don't think that's where you want to go. But that's not the only way of doing meditation. There are lots of very gentle, soft and ways of introducing and offering. I agree with Helen, it's patient by patient. But what I see is people often in the health sector say, that group of patients, that won't work for them. Mm. And I think I agree with Helen, that's a dangerous assumption to make. There may be people there who clearly that's the case for, but there may be many people in that cohort who clearly would get enormous benefit from some very gentle introduction to self-compassion practices and to some mindful some insight meditation at a very, very gentle level. So I would, and I've experienced this a lot, and unfortunately, I'm going to say this, I'm going to be direct, that particularly from psychologists who work in the health sector. I don't know why that is, but there's a lot of resistance there. Yeah. More than clinical psychologists out in practice. That's just an observation.
Perhaps I should just clarify, I don't think she was making a blanket statement about everyone that has this situation doesn't apply to. I think she was making it as a real cautionary thing to consider, and perhaps it's linked more, I think, Helen, when you talk about people with PTSI, just some cautionary around that. But I guess it was, from my perspective as a teacher, my feeling was, what comes first? I felt like it was a little bit like the chicken and the egg.
Yes.
If we don't give people the opportunity, then how do we ever get to there? So that's why I was very interested in.
It's a good question, Fiona, and actually I think Marion Turner's question also speaks to this, if it'd be okay. Marion, would you like to bring your question up now? Is this perfect to go after this one? You might have to unmute yourself, Marion. Yep.
Sorry about that. Thank you, everyone. This has been wonderful. I've really enjoyed this today. I was just wondering if you could give some insight into what you would describe as the main criteria for excluding people from groups
Well, I can answer that pretty quickly. From a mindfulness-based stress reduction perspective, we definitely exclude people who are currently experiencing a severe psychotic illness. So if they're suffering from very severe depression or in a psychotic illness such as schizophrenia, we definitely, or people who are receiving intensive psychiatric intervention at the moment. That doesn't mean that people who've had psychiatric intervention in the past may or may not be suitable, but certainly if they're in an acute phase at this stage, we would say this is not the right time for you. And then in the interview, pretty much what Helen said earlier, if we get a sense that there is a lot of distress at that point where we think that a group setting may not be the right thing for them, and this is really hard to sort of define specifically, but in talking to people, getting a sense of there's a lot of emotional charge around what's bringing them to look for some help from something like meditation, and just getting a feel for, is this person's need level going to be greater than a group setting might be able to provide, and would one-on-one intervention be better? Did you want to add anything?
Yeah, I did. The book that Joe talked about was by Mark Williams. He was part of the 3 guys that got the mindfulness-based cognitive therapy going. And if you've had a history of depression and it's stable, then they're fine to do a meditation course. There's good evidence that it reduces the risk by 50% of recurrent attacks of depression. So I don't think it's... you've also got to realise that we're not therapists.
No.
Some people who teach meditation maybe, but I'm not. And therefore we've got to realise what we can achieve and what the limitations are. The other thing is PTSD. It used to be thought of, well, you're going to get them to get in touch with their body. This could be all too much. But in fact, it's counterintuitive. The results for PTSD have been quite good with MBSR and similar courses.
Great.
Thank you.
Would it be all right if I picked up on something that came from the previous question, just to like what both Joe and Tony were saying earlier about, and also Helen, meditation's not just about what happens on the cushion, and gratitude practice is something I'm addressing, actually returning to Fiona's question. There's more than one way to meditate, and it's not one size fits all, but there are certain little tiny things, like even just, touching the warmth of your skin or enjoying something in your surroundings that could just make a tiny bit of difference, 10%, as Dan Harris might say, that could actually provide 10% more or less struggle or more happiness, or whatever you want to call it, choose your word. But I think what's incumbent on us and as meditation teachers is to realise options. It's not one size fits all, and to get creative, especially if you have people presenting in your group who have various issues. And once you do that, it's quite extraordinary what one tiny little shift in perspective can do. And it's really, I think we can put our hats on, or we can collaborate even with the student or the person that we're dealing with to see if we can provide something for them that fits into that mindfulness in daily life, less formal type of meditation that might help.
That's great, Megan. Thank you.
And I'll just make one comment quick just about that. One of the things that can really help is if you just have a co-facilitator as well, so that when things do arise in the sessions, that there's 2 of you and one of you's leading, a bit like today having Megan and Lisa. It helps. Somebody's watching the logistics while somebody else is talking, and that, I think that's really helpful when you're running groups, particularly if you feel that there's, some level of intense, there might be a bit too intense for people or whatever.
It's a great point.
Great. Thank you. The next person I'd like to invite is Jackie Dunbar. Jackie, you had a couple of questions in the group chat that you wanted
I did. Yes. Hi, everyone. This is so much to digest here, so I'll try and keep my questions brief because I know we're running out of time. I was in breakout group 4, and one of the questions we had was, what are some effective strategies for people who are in pain but also have difficulty breathing? People with bronchiectasis or COPD can find the focus on the breath quite challenging, and for others in the group find it quite relieving. And the other question is related to the use of imagery and meditation. So I think the discussion that we had before talked a lot about finding, like accepting the feelings that we were having and those sorts of things. And I was wondering if the panelists could share with us about what their thoughts are on finding a safe space in meditation and teaching about a safe space, like for iRest Yoga Nidra, which was mentioned in our group.
Yeah, I think that's a really, really good question. I think certainly patients or participants who have respiratory difficulties certainly going to find paying attention to the breath difficult. But also very often people who suffer from anxiety can sometimes find turning towards the breath actually ramping up their anxiety. Sorry about this noise in the background. So that can, one of the techniques that we use there is to actually invite people to choose a different focus. So we'll say to the group, right now we're going to be paying attention to the breath, or for those of you for whom this is a difficulty, we invite you to do one of a number of things. One would be to pay attention to sounds as they arise and pass away. The other one might be, and this is particularly helpful to people who suffer from anxiety, pay attention to the sensation of the soles of your feet on the floor, getting a sense of your groundedness and stability. This is particularly for anxious people, and really tuning into those sensations of connection with the ground beneath you and the solidity of the earth beneath you, the sense of gravity, and it's the way in which it is holding you in a state and giving you a sense of groundedness and stability. So that's what I usually use. Or maybe some other focus. It might be guided imagery in the insight meditation tradition. We don't use as much. It's not something we focus on, so we tend to mainly use different areas of focus. So that would be my main offering there. Helen probably has to offer. Thank you.
Thanks, Jo. I think Jackie, Ian Gawler has some information about using guided imagery, if that's something that interests you. I know there's a section in Peace and Bind on that, around using white light and other types of imagery for pain, so that might be something to look into. And David Fontana has, I think, some information on that too. Helen, did you have anything to say around that?
No, I think that's kind of covered it. If Jackie feels her question has been suitably responded to.
Yes, no, that was excellent. Thank you. I think it's the information is there in my brain, but it's sort of being able to maybe, like Megan was saying, about being creative and thinking about those, sensations and listening to sounds and those sorts of things, and which I do already, but yeah, thinking about creatively about that.
Okay, thanks, Jackie. Fantastic. Megan, do you think we have time for one more question, or shall we wrap up? Yeah, okay.
I absolutely, sorry, 2 thumbs up. Yes, I do. I think absolutely, sure.
Okay, yeah. There was a lovely question there from Chrissa. Chrissa, are you still here? If not, I can read the question out. It was a good one.
Maybe read it out, Lisa.
Yeah, okay. Chrissa said, if someone has lost limb in the body, what is the best way to apply the body scan meditation? What sort of adjustments might you need to make, or would you make any?
I'm happy to answer that from the experience, not having lost a limb, but having lost other part of my body, and that is that I would say that what Tony said earlier, imagining, so bringing to mind imagining that that limb is there, because we know, and this is to come back to pain, and I've experienced this phantom pain, that even though that limb is gone, that person might still feel pain in their knee or their foot or some part of that leg. Likewise, I felt pain in that part of my body that was gone. And what, rather than getting caught in a thought loop of, why am I getting this pain? That's not, that leg's not there anymore. That part of my body's not there anymore. This shouldn't be happening. And the kind of proliferation of thinking that can lead us into catastrophizing and amplifying what's happening. Noticing, that this sensation is arising here, and imagining that leg is there, and approaching it in exactly the same way as if the leg was there. So bringing that curiosity and approach to the pain there, being curious about the nature of it. Just, is it heavy? Is it light? Is it dark? Is it clearly defined, or is it fuzzy around the edges? And the more we bring a curious attention to it, the more we have this capacity to get some perspective and some distance from it. So in a way, really, the fact that the limb or the part of the body, from my experience, is no longer there, when I started to experience this pain, pain arising there, and then the thought, but it's not there, and then just coming back to, as though the pain is still there, the sensation is still there, so approaching it in exactly the same way as I would approach pain in any other way. And I've found that really helpful.
The other thing I would add would be, what attitude do I bring to that area? What emotions are coming up? Is there grief? Is there sadness? And if there is a bit of mental proliferation, to see if you can catch that, and to see if that pattern of thought has happened before, so you can short circuit it before you develop into rumination.
Yeah. How do we meet it? That's the question, isn't it? How do we meet all of this? Yeah.
But Tony's right, that really noting the emotional component of it, the grief and the sense of loss and disfigurement or whatever else might be there in relation to that lost part of the body too. I think that, and including that in the compassionate and gentle stance that we bring to it, I think is really critical.
That sounds beautiful, Jo. Thank you for that. And I love the whole holistic approach that you bring to this conversation, bringing in the emotions, bringing in the feelings and the energy, and bringing in the physical aspects as well. It's really beautiful. Thank you for sharing so generously to everyone.
And there is, someone's made a really good point too. Yes, absolutely. Today's session has been focusing on mindfulness-based pain management for sure, but Tina wants to point out that there are many other meditation modalities. Yes, there are. IRS has great pain management strategies proven in clinical trials to be effective. So whatever your technique or modality, always to be able to explore that and how you can bring that to something like pain management. But yes, today has been an exploration of mindfulness-based pain management.
Thanks, Megan. Right, so I think we're going to wind up from here. Megan, did you have anything else you wanted to mention before we finish off?
Yeah, I'll just remind everybody again that I've put my email address in the chat box. So if you do have a burning question that wasn't answered today, please do send it to me, and I'll do my best to point you in the right direction. I've also I'm just sharing with you a link to Breathworks in case any of this has piqued your interest about their pain management and mindfulness program. So that's there for you to take away with you if you like. If you want to find out more about Jo and Tony's work, you can visit mcfm.com.au. Helen Perry is on LinkedIn at the moment, and hopefully, and if you'd like to find out more about what Meditation Australia resources too, you can also visit meditationaustralia.org.au and find out more about the resources and services and where to learn and things like that with us as well. And I just wanted to say thank you, basically. before I hand back to you, Lisa, to take us out. But huge thanks to all of you for coming today and your kind attention. We hope you got some benefit from this. I certainly have. And also to our amazing speakers and to co-host Lisa Ford extraordinaire, and also to Vidyamala Birch for the interview. And there's in the chat box again, there's a link to the video should you wish to have a look at that. It's available to purchase from now.
Terrific. Thanks so much, Megan. And the recording of this meeting today will also be available for those who have attended. So we will email that out to you. Thank you so much, Joe, Tony and Helen. You've been so generous in giving and we really appreciate it. Thank you, Megan, for organising this highly informative event. It's been, and that wonderful interview with Vidyamala, which I personally found so enlightening and highly recommend to everyone if you can get to see it. Thank you, everyone, for your participation and support. And I wish you a very happy meditation teaching journey on behalf of Meditation Australia. Good night and thank you.
Thank you. Bye.
Thank you.
Bye. Bye.